This meeting is not being broadcast live, but it is being recorded and will be available to watch on the CCG website after the meeting. Members of the public have been invited to join and may be watching the meeting live. I'd be grateful if members of the public can turn off their microphones and camera during the meeting. There will be an opportunity for members of the public watching the meeting to ask questions about any items on the agenda or to ask for clarification if they're uncertain of anything that is being discussed in the meeting. This can be done by raising your hand at the slot at the end of the meeting for questions, or raising your hands if questions are invited on any item by myself, the chair. Members of the public can also raise questions by email during the meeting to nwccc.communications@nhs.net. If the question relates to an agenda item, then this will be read out at the end of the meeting. The governing body will either answer the question or defer the answer, in which case a response will be prepared in writing to the requester within 7 days of the meeting, and the answer will also be set out on the CCG website. I'll remind everybody that the governing body meeting is a meeting of the CCG which is being held in public, but it's not a public meeting. Accordingly, any questions which are not related to agenda items will be answered and displayed on the website, but will not be read out during the meeting. Finally, a reminder that the meeting is being recorded and will be in the public domain, so members of the public are asked to refrain from sharing any personal information or information relating to third persons when raising questions or when requesting clarification regarding items on the agenda. Okay, so I mean, as way of introduction, I ought to acknowledge really that today will be the last meeting of the NHS Norfolk and Waveney CCG governing body in public before the CCG ends on the 30th of June, at which time the NHS Norfolk and Waveney Integrated Care Board will be established on the 1st of July. We are joined today by Right Honourable Patricia Hewitt, who will chair the ICB, and I welcome her to the meeting. The ICB will signal a new way of working across Norfolk and Waveney health and care across our area, and I very much welcome that. As a CCG and personally as chair of the CCG, I've been doing my best to ensure a smooth transition from the CCG to the new arrangements. And the transition really started 2 years ago when the CCGs across Norfolk and Waveney merged into one CCG across Norfolk and Waveney. I will say a few more words at the end of the meeting in relation to this being the final meeting, but I just wanted to take that opportunity particularly to wish the ICB and Patricia in particular success for the future, because I know that Patricia won't be able to join us for the whole meeting, so I just wanted to take that opportunity to say that. Patricia, did you want to say something?
If I may, and Anoop, as you've just recognised, unfortunately, because of the Quality Summit with NSFT, I'm not able to stay for the whole meeting. But I just wanted to thank you very much for all the work we have done together in making this what will be, I'm quite sure, a smooth and successful transition. And I really want to thank every member of the CCG governing body, and through you, all the wider members of the CCG for all the work that they've done in recent years. We will be building on those foundations as we move forward into the new Integrated Care Board, and I look forward to working with all of you in different roles in that different architecture that the NHS is creating. But it's a wonderful opportunity, and as I say, one where we are building on all of your achievements, not tearing them up and failing to recognise them. Building on them, I think, is going to be key to our success in the future. So thank you very much, Anu.
Thank you, Patricia. Okay, well let's move on to the agenda. We've got quite a lot on the agenda today, so I will ask people who are speaking to the items and for discussions to be kept to time, and that we've got some timelines within the agenda to keep to. So item 2, apologies. I haven't received any formal apologies. Are there any that we've received, Jane, or is everybody here?
No, Kathy Branson and Andrew Palmer and Francis Bolger. Okay,
we'll note those apologies then. Item 3 is declarations of interest, and firstly a reminder that that we should keep the register of interests up to date and accurate, and a particular request for any items which people feel they may be conflicted or maybe seem to be conflicted. Can they raise them either at the agenda item when we come to it, or if they want to make any declarations now, can they make them, please? Karen.
Thank you, Anoop. I'd like to declare my son-in-law as a registrar at the Norfolk and Norwich Hospital in cardiology, and my daughter is an OT employed by NCH&C. Thank you, Anoop.
Okay, thank you, Karen, and we'll note those in the minutes. So item 4 is to approve the minutes of the last governing body meeting which we had. So if you can have those minutes in front of you. That was held on Tuesday the 23rd of March. So initially I'll take those minutes and hopefully approve them for accuracy. So are there any items or any points of accuracy? Karen.
Thank you, Chair. Not a point of accuracy, but just to, under agenda item 1, just to set out, there was one Chair's action that was to do with the financial plan approval from 22-23. So just that's with the papers for anybody to have a look at, but I just wanted to formally note that on the minutes. Thank you.
Well, thank you for reminding me about that. Thank you. Okay, so any matters of accuracy on the minutes of the last meeting? I'll take them as a whole. I'm not getting any items for accuracy. So are there any matters arising from those minutes which we're not covering on the agenda today that people want to raise? Okay, so we'll sign those off as accurate, and there's no matters arising that we need to bring up. In which case we'll move to the next item on the agenda, which is the action log, and there aren't any outstanding actions which have not been completed. So we'll move to item 6 then, which is the Chief Officer update, which was sent out with the papers. Tracy, do you want to go through that?
Absolutely, Anoop, thank you. I will take the document as read, but I just want to pull out some key themes. So obviously we're talking about the NSFT CQC rating later on in the papers, but just wanted to reflect on the fact that I know most people in this meeting will have read the CQC report, and it was a very difficult report to read. We are not providing the care, the level of care or the safety that the residents of Norfolk and Waveney deserve. What I will say is that moving into an integrated care system, we are taking a systems approach in supporting NSFT, but also looking at mental health services and support across the entire system, which is the right thing to do. We won't just have problems in one organisation, but some of the cause and effect of that will be felt across the whole system. And also the people that we support with mental health issues will be accessing all different parts of our system, and not just health, but also social care and the wider determinants of health. So whilst we are supporting NSFT and working with them to improve the quality and safety of their care through the Quality Summit this afternoon and further CQC inspections and meetings and a package of support, I just want to make it very clear that we are looking at all organisations and all services within the system with a view to improving them until we get to the point where we're providing services that we would be proud of and that we think that our residents deserve. And I would also say that I expect this to take a while. I expect us to be working on this for several years, and I think it will also help us with improvements across the rest of health and social care and the rest of the services that we provide. So incredibly serious. We are putting a package of support together. And I just want to say a thank you to the staff of NSFT who are going through a difficult time at the moment, but have also worked very hard through the pandemic as well. Just moving on to wider system pressures. I also want to say a big thank you to everybody working in general practice. It's incredibly busy at the moment, and I know that we're having problems recruiting and retaining some of the support staff in general practice as well, which isn't making life easy. However, what I would say is that the enthusiasm of general practice to work with us to look at providing more services in communities so that people don't have to wait for long waiting lists and go to the acute hospitals for services. I've been bowled over by, actually. I think even though general practice is under extreme pressure at the moment with people coming forward when they may have waited through the pandemic, the ideas and the enthusiasm and the energy, I think it's fantastic, and I think that very quickly we will start to move more services into the community, which will help to reduce our waiting list. So big hats off and thank you to colleagues. In terms of hospital activity, it's still extremely busy. Whilst we're seeing less people in hospital with COVID and less of our staff are suffering from COVID as well, so our sickness levels are reducing, hospital occupancy, ambulance handovers, length of stay and ambulance response times are not decreasing at the moment. That said, we are in a slightly better place. We're discharging more people from hospital when they don't need to be there, and we have something around the figure this morning of 320, 325 people in our 3 hospitals who don't have a right to reside, which is an improvement of around 120 from the previous week. So efforts to get people out of hospital when they don't need to be there are really starting to pay off. And it feels like we are in as good a position as we can be going into the long bank holiday weekend in terms of planning as well. In terms of becoming an integrated care system, I'm really proud of the work that the CCG has been carrying out over the last several years, and I think that's a really strong base that we can build on. There's been an awful lot of work happening over the past few months, so getting our constitution ready, getting our board set up, all sorts of delegations, but also some quite exciting things, thinking about how we structure place so that we can devolve more decision making and more budgets down to place level, looking at how we work with the voluntary sector in a better way as well, and some of these ideas and initiatives for community delivery of more of our services, which I think is really exciting. So lots of work going on at the moment. Cutover date is the 1st of July, and you'll be hearing an awful lot from communications colleagues about that as well. And then I also wanted to highlight a couple of things that colleagues may not be aware of. So the first is that we have a substantial budget for transforming Care Navigators, which I'm really pleased about because I know that this programme means an awful lot to people with a learning disability and their families. And also, if you haven't checked out the video that we've tagged from the NNUH virtual ward, do go and have a look at that. I think it's fair to say that people don't want to be in hospital when they don't need to be there. But if we can either reduce the wait that people have in hospital before operations or get people out earlier so they can be more comfortable back home, but still have that security of being monitored, then I think we can all agree that that is an improvement for our patients. And some of the tech that we're using to do that and some of the structures and clinical structures that we've put in place are really interesting. So do take a look at that if you can. I'm going to finish there, but I'd just like to add my thanks to Patricia's thanks to everyone on the governing body and everybody who's been involved in the CCG. I've only actually been accountable officer for less than 2 months, but your support has been invaluable as I've been getting up to speed with the role. And I'm sure I will continue to be calling on you over the next few months. Thank you.
Thank you very much, Tracy, for that report and those words. Any questions on Tracy's report or any comments? Okay, thank you. Well, thanks very much for your report, Tracy. So let's move on then to the remaining items. So item 7 is to receive and approve the Norfolk and Waveney Learning from Lives and Deaths people with learning disability and autistic people. I think, am I right in saying, Karen, that you're going to start the discussion on that?
Yes, Anoop, if that's okay. I'd like to introduce everybody to Andy Hudson, who is one of Sarah Jane's deputies. Andy has been part of the co-authoring of the 5th report of the LEDA annual report. It's an excellent report. There's an easy read version as well for people. The report really sets the heart and mind in what we need to be doing to learn from, sadly, deaths of young people or older people with learning disability and autism. And it sets out a series of recommendations and also makes significant reference to the tragic loss of life that we saw from 3 FARs that were reported. So without further ado, I'm going to hand you over to Andy, who will give you a little bit more of a background and introduction into the genesis of the report. Thank you.
Thanks, Karen. Yeah, as Karen said, I don't think there feels a more important time in light of the Safeguard and Adult Review last year. And whilst Joanna, John and Ben's reviews haven't been reviewed as part of this year, they'll sort of be included for next year. I guess it really identifies the huge importance for us to embed the learning from those reviews to make sure our offer for people with learning disability and autistic people is absolutely where we want it to be. This is the 5th annual report. I guess some of the key bits to draw upon is there was certainly a change in review process and national policy during last year, with some significant changes to some of the governance elements, but some of the key parts to that is meant that we've had a dedicated team to undertake leader reviews, which has been significantly important in terms of our progress to complete them in a timely manner, and for us to work with the local system in terms of how we embed that learning. You will see that in the bulk of the report, the median age has reduced slightly, but some of that is felt that actually this is the number of reviews undertaken has given a more, I guess, accurate age. We've also seen lots of work across different areas of that need to be reviewed. Importantly, we're seeing a shift away from hospital as well. Whilst hospital still remains the place that many people died, we are starting to see an increasing number of those dying at home. And last year, which isn't necessarily uncommon, but we certainly saw respiratory illness as the key factor for why people died. I won't go through all of the 16 learning points. There's lots there, but lots of them draw upon things like Mental Capacity Act, annual health checks, respect, DNA CPR, and reasonable adjustment is one of the key elements to make sure that the kind of those pathways and that journey for the individual is how it should be. So happy to take any questions from the report.
Okay, thank you. Thanks, Karen and Andy. So questions and comments. So Tracy first.
Yeah, thank you very much, Karen and Andy. I mean, it's really good to see this report. Certainly, we know we've had a more important kind of families have had a very harrowing, year with events that happened. So it's really pleased to see we have this report and the progress that we're being made. I think for me, in respect of the learning and the sharing, that absolutely it's probably needs to be, and hopefully it is more widespread than just kind of health colleagues. It's health social care colleagues. It's all people that are having, contact in our system with those people that do have a learning disability. And I think there's so much more to do in kind of those everyday contacts, particularly with what we wouldn't necessarily think are health services, but they are those contacts where we do have that difference, because a group of our community that really have huge disadvantages and suffer health inequality. So really keen that we kind of look at this in a broader sense in people's everyday lives as well. I'm thinking about dentists, I'm thinking about opticians, all places that we share the learning from this as well, and make use of those contacts really where we can. But I know there's a huge amount of work in train, which is really positive that the teams are doing.
Okay, great, thank you for those comments. Arden?
Yes, just to echo that, thank you very much for an excellent report. It certainly was made very good reading in terms of the progress that has been made, particularly around the health checks. Delighted that 66% of health checks have been completed this year, which is obviously great progress. I think along with everybody else, love to see more being done in terms of ensuring those health checks are one-stop shops so that we can include health screening, vaccination, long-term condition reviews with reasonable adjustments being made in order that people can access everything all in one go. And I think that's obviously clearly must be the next stage, bearing in mind that so many people are also dying from cancer in this cohort. So we need to include the health screening. The other bit that we haven't perhaps drawn as much attention to is around the mental health support for people with learning disabilities and autism. And many of our mental health programmes are beginning to really start to address this, but I think clearly much more needs to be done in this area.
Thank you. Any other questions or comments? Karen?
I think for me, one of the pleasing things in the report, Andy, was around seeking sort of experience and engagement from individuals, because that is absolutely critical to delivering the service. It's about being listened to and having time to be seen, and making sure as you tell your story only once that you have a passport that actually helps, that this is me, and it helps you when you access services. So I'm really, really keen that we don't lose that as we move forward, that the engagement and the co-production and listening to people is absolutely critical. Thank you.
Thank you. John?
Thank you. I just wanted to comment on the annual health checks as a member of the primary care committee that's had a very significant focus on this over the last year. And I think a lot of the discussion has been around the quality of the checks, or ensuring the quality, and also making sure we don't hit the target, miss the point. So 66% a good result, but actually what about the other 34%? When will those people get done, as opposed to starting again and maybe doing the same 66%? So there's been really good conversation throughout the primary care committee on that this year. And I suppose just thinking about transition to the new organisation and making sure that we don't lose that focus, I think, going forward.
Yeah, no, absolutely. And I think when I read the report and listened to the comments, as a GP working in primary care, I certainly agree that that the health checks are an enormous initiative, which actually, we're in a lot better position, I think, than we were a few years ago, but there's still a long way to go. And I think some of it is about the thoroughness of the checks that are being done. And I'm really pleased that practices that I've seen are giving more time to, particularly their nurses, to spend more time with these patients, to actually get into the detail of the issues that are affecting them. And as others have said, not just physical health, but mental health as well. And as you just said there, John, it's what about the ones that aren't reached? Because I think we've found, particularly with the pandemic, that access to services has been affected for everybody, but particularly this group, I think, are more vulnerable, and access is going to be even more difficult. So I think the more proactive we can be to reach those that don't normally get the service, the better. And I think that's one of the challenges for us and others going forward. Okay, so thank you very much, Karen, for leading that, and Andy for presenting that report. And unless there are any further comments, we're asked to approve the annual report for 2021. So can I ask for your approval of that report? Great, thank you very much. And thanks again for bringing that to us. So let's move then to item 8, which is to review the outcome of the Quality Care Commission inspection, which was published last month on Norfolk and Suffolk Trust, Foundation Trust. So I've got, it says Frances Bolger, but she sends her apologies. And I think, Karen, you're going to start the discussion on this report.
Absolutely. Thank you, Anoop, and thank you, everyone. I'm going to take the paper as read, but I'd just like to draw a few highlights through, if that's helpful. So in terms of the recent inspection, as you're aware, the organisation was inspected at the beginning of November. And following that inspection and the issue of the report 6 months later, the trust was found to be inadequate, moving from a rating of requires improvement. This is an organisation that has been in and out of special measures. I think it's important to recognise that from the immediate findings of the report from the inspectors, that a huge amount of work has been undertaken. And as a consequence of that, the CQC did not serve a letter of intent under Section 31. They were definitely assured that immediate concerns had been addressed. However, they did serve a Section 29A warning relating to 5 registered locations, which are listed within the report. The Section 29A warning notice, in essence, spoke about maintaining safer staffing levels, ensuring suitably qualified staff were there to meet the needs of the people using services, and to really focus on basic elements such as mandatory training, which are very important, staff receiving supervision and appraisals. There were some environmental issues that were of concern, and it was regarding staff aware of ligature assessments and making sure that patients had risk assessments to manage risks and ensure patient safety. There were also elements of not managing waiting lists and monitoring the risks within those waiting lists effectively. What I can say is that there were other issues raised around the leadership, about some leaders being more consistently visible in the services and approachable to patients and staff. It was about a conversation regarding their vision and strategy, about turning that into action, and that there were some cultural elements noted as well. In line also around some of their governance processes that needed some strengthening. We also looked at some of the information and looking at their data and how it was analysed. And really, it was about really focusing on workforce and continuous improvement. What I can say during that time, and what I have observed since I've been visiting the Trust quite regularly over the last few months, is that I have seen, as the report alluded to, good care. And I've seen very compassionate care in some of the areas that I have significantly visited that have been highlighted in the 29A. And I've had the opportunity to talk to many service users as well, who also reinforced that the staff were kind, caring, and they were listened to. I also feel people in distress and how sympathetic and empathetic the staff were and how supportive they were in reducing that level of anxiety and agitation. One of the things that I'm pleased to say is that I feel as an organisation, our system partners, as Tracy said, it isn't all NSFT, it's about how we respond as an emerging ICS so that we work together as a health and social care partnership to resolve the issues. Some of the issues relate to social care and some relate to the patient pathway, which needs working through as we progress forward. I can reassure to say that a number of internal inpatient areas have been completed with safety visits, quality safety visits, of which my team have been part of, and a total of 38 have been undertaken since the report was first brought to mind in November. I've also allocated 2 members of my team, and I have 1 member who's fully available and visible, both are visible on site, and supporting the Trust with things that are supportive and helpful to them. I'm involved in many internal meetings that I'm invited to by the organisation, so any evidence panels which are being set up, the team reports, and it's really a case of how we broaden that offer and we work with the organisation to make a difference. So I think recognition of progress is that we must recognise that staff have also been through a pandemic. They are tired, they have gone above and beyond. Many are very demoralised. They're working with a number of vacancies within the organisation. The organisation has strived to make some really significant innovative ways of working. So they are using advanced practitioners, consultant nurses, and where there are gaps there, they're endeavouring to meet the gap. But to meet the gap does take time and take training. But they've held a number of open forums and they have recruited a number of clinical support workers too. And equally, in areas where leadership hasn't been as strong, they have moved people to strengthen those areas and offer more stronger support with their matrons. I think we do need to consider what we need to do to help, and that is around our STP, or rather, that's a very old turn of phrase, I do apologise, ICS workforce team, and how we can support that development of staff, and also Health Education England in looking at the medical staffing model. So I'm very happy to take any questions. It's a very detailed report, and I can just reassure you that there is a quality summit this afternoon, which Patricia is attending, and Frances, my colleague, and I'm sure we'll be able to bring you a further update as we emerge into an ICB. Thank you.
Thank you. Thank you very much, Karen, for that. I'll open it up for questions and comments. And while I'm waiting for that, just to emphasise, I suppose, really the importance of this. I think, and the fact that, you know, some people that would be here at this governing body are actually attending a quality summit, I think is a good thing, because it shows that the focus is on where it should be to make sure that we that we do what we can as a CCG to support the improvement that needs to happen. Hopefully I know what the answer to this question is, but one of the bullet points in terms of recommendations and next steps, the penultimate one, is that Norfolk Waveney CCG will continue to be visible, supportive and challenging partner within the system. Now, clearly the CCG won't be continuing anyway, but can you reassure us that that the senior managers, clinical leaders that are working within the CCG will smoothly be able to continue that work as we transition from one organisation to another?
Absolutely, Anoop. I really see the importance of this in facing two of my most senior nurses to support, and myself. And I've been out nearly every week visiting, and it's more staff engagement at this point, because I think it's important for the staff to realise that we are here to support, because it's all our population, whether we're a commissioner provider or another partner, it's our local population, and we need to support in the right way for that organisation. But also, I'm their critical friend, and if I see things or can improve things or support, that's our role, to help and support and be a critical friend at this point.
No, thank you for that, and I had no doubt that that's what you would say, but I just wanted to confirm that, you know, we're going through organisational change, but actually the focus should be on the services that our population receives. So we mustn't lose the focus of what we're all here for and what the ICB will be here for as well. Thank you for that. Mark, and then Tracy.
Thanks, Anu. Karen, could you just say a little bit more about what the process will be for tracking progress with the improvement plan? Clearly, I understand the CQC will carry out further inspections, but what will the ICB be doing to check that there isn't going to be any slippage and there are no surprises?
For us, Mark, as an ICB, we're part of all their internal meetings, but we have a weekly improvement board, which we attend weekly, where the improvement plans are absolutely gone through with rigour. And they have adopted a very similar approach to the approach taken with the Queen Elizabeth Hospital in King's Lynn. So we are very cited. I think it's also making sure that we keep the traction, because often what we see so readily is that we make improvements and then we don't sustain. So for me, some of the things we've seen are core things that should be and would be relatively simple, but it's making sure they're embedded, as opposed to, yes, that's done. It's making sure they're absolutely embedded and that things are recorded, that observations are taken, that the governance is strengthened. And for me, it's about the organisation having that additional support to be able to achieve that. I hope that answers your question, Mark.
No, thank you. That's very helpful.
Okay, Tracy.
Yeah, thank you, Karen. That's really helpful to hear the report, and I'm really pleased to hear that some progress has been made already, and the system is kind of running around and supporting the trust. I was particularly interested thinking about the elements of the low staff levels and recruitment and staff morale, that there is an element that links to the culture, isn't there? And I guess there's going to be a huge amount of work in respect of the culture in the trust and supporting those staff. But just thinking about the culture of our system as a whole as we move into the kind of the new system, the ICS, and how that support can kind of be there for that culture overall, because I think that's going to be crucial really going forward. So I'm sure there is work, and I know there will be work, but it's just a little bit on that is helpful to know, really.
Yes, there's definitely work, and as you know, Kath Byford, our chief nurse, who's recently left, obviously is the chief of people, and one of her key roles will be culture, and part of going out and talking to the staff is around the culture. I think the organisation have got their eyes wide open where they feel there may have been some cultural differences. They have strengthen leadership in those areas. But one of my recommendations is that they really focus on that culture and OD work, because you need to value your staff. It's not that they don't value the staff, but it's about investing in bringing that workforce forward and retaining the staff. So I agree with you, Tracy. I think relationships are key for us as a system, but it's also key that internally the organisation has some very focused work on culture and their OD culture as well, because that's how you retain and value staff. Thank you.
Okay, Arden?
I think it's worth recognising as well that it's a fairly new leadership team that have in charge here, and they haven't really had much time to bed in. But I think we're seeing huge willingness to make changes, and importantly to work in partnership. And the partnership board is a really strong forum now for, I think, for ensuring that change takes place. But coupled with that, I think there's a recognition that we need stronger clinical leadership and a real focus on bringing those clinical leaders to the forefront to lead on new service developments. So I think there is the potential for change here, and we are seeing some green shoots. I think the other really important thing for me is linking this work with the CQC action plan in with the community transformation that's taking place. As people are aware, we won the bid for investment in Norfolk and Waveney mental health services last year, and have already put in place, in collaboration with all of our experts by experience and partnership organisations, a very strong community transformation programme, which includes a huge emphasis on prevention, moving services into primary care, development of new roles, linking with secondary care services for people when needed, but linking very much around partnership with voluntary sector. So a lot of really good work going on, which needs to bed in. So I think the key to success here is about us working in partnership, establishing those connections with the community transformation programme, and really supporting that programme to take shape and to deliver what we need it to deliver.
Okay,
Absolutely.
thank you. Thanks very much for that, Arden. Hilary.
Hi, thanks, Anoop. I was just going to ask about recruitment, because that seems to be a recurring problem for a number of our organisations across the system, but particularly for NSFT. So it's really good to hear that there's some new roles, and that sounds really encouraging. My question really was, is there enough support coming from university, from Health Education England? Are there other things that we could do that maybe other parts of the country are doing? Because I know that mental health staff recruitment is a challenge across the country, isn't it? But I know it's a particular challenge when you have a trust that's under scrutiny. So I guess my question really is, across the wider education system, is there more that we could do to support them? Because it's very difficult to run a service if you are continually going out to try to recruit staff and you just can't get people to apply for the posts.
Absolutely agree, Hilary, and I think there is things we could do around health education. We need to really focus and prioritise, particularly around the medical staffing element, because we can put as many sort of variations of roles in, and they are equally augment each other. You do need psychiatrists, and you also need to be able to support that recruitment into an organisation that's in challenge. But thank you for raising that, and yes, that's something I think we should take forward.
Would it be okay just to come in briefly here? I think you'll be aware of the CAP programme as well, Hilary, where we're the associate psychologists coming through the UEA. So that's a programme we've had in partnership, and the first cohort are already beginning to come out into the community team. So that's very exciting. We've also developed the mental health pharmacist role, and then this year Mind has trained and recruited recovery workers for all of the PCNs. So we're looking to our voluntary sector organisations to recruit some of those roles as well, and very importantly the peer support workers coming through the recovery colleges. So there is a massive amount of work going on, but I mean clearly more to be done, but very aware of that, and where we could possibly bring those people in from using VCSE, etc.
Okay, thank you. So if there aren't any further comments, I think we're asked obviously to note the contents of the report and the further actions that are required. And I think particularly we've had some good discussion, and hopefully that will give you some points to take forward, particularly I think in terms of further actions, that focus that Hilary and Adam mentioned on recruitment and retention of workforce, which obviously it's a crucial area. So perhaps you could incorporate some of that in terms of the support that we're giving to NSFT. So thank you for that. We're asked to consider the report which we've done and further action. So thank you. If there aren't any more questions, we'll move on then to item 9, which is to receive from Doris Jameson, who's our Freedom to Speak Up Guardian, a report for the year to March 2022. So Doris, do you want to talk through your report, please?
Thanks, Anoop. I will take the report as read. I'll just make a few comments on things that have changed since I wrote the report. Since the end of the financial year, 2 further cases have been closed. So currently we have 1 case that is still open. And I think one of the learning and for the new organisation to think about and to bring forward is that how do we encourage people to speak up earlier? Because sometimes when people do speak up, it's quite late. It's very difficult to have an objective investigation and bring forward sort of remedies that they might be more happy with. But the key, I think, is actually encouraging people to speak up earlier if they can. I think we've got some 4 new champions that have joined to support me. So the role of the champion really is to do signposting and to raise the profile of speaking up. Unfortunately, champions can't do any casework. So if somebody wants to come forward and raise the concerns, champions can't really take it forward. So it's important as we move forward that there is somebody to take on this role within the ICB. And looking at the statistics in terms of the people survey, although we score more than 50%, and you could say that's good, I would say we could do better. And I think looking forward as we transition to the ICS, we probably need the Guardian to have more ring-fence time so that they can actually look at the data and do more proactive work rather than my role has been very reactive and partly my time commitment is limited as well. So I'm happy to take any questions, and I just hope those points will be helpful for the ICS as they go forward to develop this role.
Okay, thank you. Before I ask Rob to come in, can I ask a question, which is on the number of cases? I think in your report, you've in this last year there were 7 cases, and in the 6 months from when it started the previous year there were 7. I mean that seems like a reduction, but I don't know if it was that significant. But my bigger point was really, you know, do you have a sense that that's kind of like the right number? And I suppose in one sense the more the better, because it shows that people are able to use, that are aware of the system, and you want to be able to look into cases in detail rather than just the more severe cases that present late. But have you got any sort of benchmarking figures from other areas, from other CCGs, in terms of what their rates have been? Because that can give an indication as to the profile of this role and whether people are aware of it.
Yeah. So it's 7. I've had 7 contacts, not all of them led to cases. So in the last financial year, which is for 6 months since I've been appointed, was 7. So if you look at just sort of pure numbers, it looks lower. I would say probably some of the cases that have been open have been more complex this year. I don't have any benchmark data, but partly I haven't had the time to look for it, to be honest. And there is starting to be developed I think the Freedom to Speak Up has been very trust focused, and the Guardian's office has been very trust focused. There are now more CCGs and other providers involved. And I'm sure there is data out there, but it just requires a bit of searching and benchmarking going forward. My gut feeling, is this the right number? I would say it's on the low side.
Okay, thank you. Rob.
Yes, thank you, Anoop, and thanks, Doris, for the report. I've always felt that this is a really important role within the CCG. My reading of the report is that Doris and her team have created a very, very solid foundation for the ICB to take forward. Inevitably, there's always more that can be done, and I think Doris has very helpfully this afternoon highlighted some areas that the ICB can take forward and build on. And I think it's important that those points are captured and built into the forward programme and development of this role. And finally, Anoop, I think we should give recognition to Doris and her team for all of the work that they've done in this area over the last 2 years. I know it's a challenging area, but we can see from this report that we have established a very strong base through that hard work. So thank you, Doris.
Thanks, Rob.
Yeah, no, absolutely, and I was going to make that comment myself. So thank you, Rob, for saying that. And can I say on behalf of the governing body and the CCG, personally, to thank Doris for taking on this role and for giving leadership and visibility for what I think is an important role, and exactly as you say, Rob, a very good foundation, and very much hope and expect that Tracy will make sure that this work continues, that there is a guardian for speaking up within the ICB, because I think it is vital that it continues. Thank you. Okay, so we'll unless there are any other points, we'll move on then to the next item, which is a standing item 10, which is to review and approve clinical threshold policy recommendations, which have come through the CCG, including the clinical policy development team and the clinical executive. So, Mark, do you want to talk through the recommendations that we're being asked to approve as a governing body?
Yes, thank you, Noob. So just in line with today's theme, I'd just like to acknowledge the work of Kim Warnes within the CSU clinical policies team, as well as my colleagues, Dr. Chris Dent, Dr. Tamer Akasha, and Dr. Mark Follows, in their help in formulating these various policies, which will obviously be ported over to the new integrated care board. So there won't be a requirement for us to review the entire list on day one, just to give incoming ICB members that reassurance. So we've got two relatively simple changes today, which I hope are self-explanatory, and I'd like to recommend them to the group. Thank you.
Okay, so you've read the recommendations. Are there any questions you want to ask or comments on what we're being asked to approve? John?
I think it's probably obvious from the documentation. Just wanted to be clear, Mark, are there any financial consequences, do we think, of these changes that we're looking at?
Yes, John. So in terms of the hair removal one, I don't think so, because I think if we had an individual funding request which related to not using a different form of hair removal, which we would have approved anyway. So there's no financial implication from that. In relation to the hip resurfacing one, we only had one request through the IFR route from that previously in the last 2 or 3 years. So it's just in case the secondary care consultant feels that that's a option instead of doing a total hip replacement, that they can have that procedure instead, which may be suitable for some particularly younger patients, and hopefully, reduce the risk of them having to operate again to replace the replacement, as it were. So if anything, that should hopefully have a positive financial implication. Thank you.
Thank you.
Okay, thank you. Any other questions or comments? Okay, Well, but before we ask to approve, I've got a question for the executive, which is that and this applies, I guess, to the next item as well. That the CCG has worked where, and I think the ICB will be in a similar position, where it'll be the accountable body that makes decisions on things like clinical thresholds and drugs policies. And the CCG has got, for example, with the threshold policies, it's got a policy development team which makes, reviews, revises, approves policies, which then go to the clinical executive, which is led by clinicians who are many of them on the governing body. And the governing body has assurance that it's gone through processes where it's been revised, and often the clinical executive does kind of ask the policy review group and other groups to look at things again before they finally come to governing body. So the governing body has a level of assurance there, not to be looking at the detail, and that actually has been properly scrutinised and amended by clinicians. But so my question is that this is the last meeting of the CCG governing body, and the ICB will have similar roles, responsibilities in the future. Are we assured that we've done as much as we can to make sure that our successor body has got the right level of clinical involvement to make these decisions? Because what roles are continuing, and what will Tracy and others, I guess, need to think about in terms of having that assurance to the board of the ICS? I'm not sure who's going to answer that question, but I wanted to just make a comment more than perhaps ask for a definitive answer. Tracy.
Hi, Anoop. I was going to suggest actually we revisit this in the second half of the meeting when Karen's with us, because she'll have more detail on the latest thinking and the latest work on that.
Okay. So thank you for that. Yeah, and I think perhaps if we just note that we will ensure that there are arrangements to ensure that continuity of assurance clinically. Thank you. So can I ask then for you to approve those recommendations which have been made for clinical thresholds, those policies to be amended? Great. Well, thank you very much. So we'll approve those. And so let's move to item 11 then, which is now to review and approve recommendations for as to drugs and therapeutics. Let me just get the paper in front of me. And is Michael here today?
Yes, thanks, Anoop.
There you go, Michael.
Okay. So two papers, which are the outputs from the clinical recommendations from Area Prescribing Committee TAG, turned into commissioning recommendations in line with local and national policy through our Drug and Therapeutics Committee, which has been to Clinical Executive Committee for clinician oversight prior to coming here. I'll take the papers as read. There's just a couple of things in the April paper just like to highlight. So inclisiran, which is a lipid lowering injection, traffic light status is in line with our local lipid pathway, and only under specialist advice should it be prescribed in primary care is our recommendation for that one. And the one just below that for weight management services commissioned by from a tier 3 provider, that Saxenda, which is the only drug NICE approved for weight management, remains secondary care or home care supplied, because that is the only way we have access to the NICE agreed price, which is quite a significant discount. So there shouldn't be any GP prescribing of that particular drug for that condition. So that was all I had to highlight. Thanks, Anoop.
Okay, thank you. So quite a long document, detailed document. Are there any questions people want to raise on what we're being asked to approve? Arden.
Oh, it's just worth clarifying that Saxenda is, of course, still available within primary care when the primary need is uncontrolled diabetes with an obesity element, but it's not prescribable as first line, just in case anybody was worried.
Okay, thank you for that clarification, Arden. Okay, any other questions or comments before we approve? Okay, great. Well, can I ask you then to approve those recommendations for drugs and therapeutics? Okay, that's approved unanimously. Thank you. Thank you, Michael. Okay, so we've got to item 13, which it says it's a break. Well, shall we have a break then? We're slightly ahead of time. I think it seems a bit early, to be honest, to be taking a break. Shall we do another? Shall we try to plough through? What do you reckon? Yeah, I'm getting some nods to plough through. Let's go through, see where it heads. So let's move to item 13 then, which is to receive a summary of the financial position for month 12. So that's the last month of 21-22, and I'll hand over to John to talk through that report.
Thank you, Anoop. So hopefully the report's fairly self-explanatory. Just a few things I was going to pull out. So it's the draft position for the end of the last financial year to March 22. It's subject to audit at the moment, which is an ongoing process. It was a positive result financially. There was a very small surplus, around £600,000 surplus, which is 0.03% of our annual spend of £2 billion. So despite the fact there was a lot of money flowing through to the NHS in the latter months of last year to support the pandemic response, to support winter pressures, etc., I think we managed to do a pretty good job of actually using as much of that as we could to flow through to services, to patient services, and minimise that surplus that we had at the end of the year. One other point I would make, as noted in the cover sheet, is that whilst that's a positive result, it does mask some underlying pressures, and particularly around continuing healthcare, where activity and prices in particular have shot up over the last year or two. Also within GP prescribing, there's some underlying pressures in the market there around pricing in particular. And those pressures were offset by some one-off slippages on some of the new monies that came down, for instance, and some support from system partners. So we had ongoing pressures offset by one-off benefits, if you like, which gives us a bit of an ongoing problem into next year, which we'll see in a little bit when we come on to the 22-23 report. So that's all I was going to say by way of introduction. And this has been through the Finance Committee for review as well, but very happy to take any questions.
Okay, so any comments or questions? As you say, John has gone through the Finance Committee. I don't know, Hein, did you want to as chair of the Finance Committee, make any comments on that?
Not really. I think that this picture that you see in front of you has sort of been emerging for the last few months, so no surprises in that regard. Just want to echo the point John made about underlying pressures, and as we'll see in the next agenda item. Thanks.
Okay, great. Well, thank you. We're asked to receive a summary of that position. So thank you very much, John, for your hard work and keeping to budget, which is our financial responsibility, a statutory one. We'll note that report and thanks for all your efforts on. I'm just trying to work out what that percentage is. 0.6 out of 2 billion. I think it's less than 0.5%.
Yeah.
So that's pretty.
But the way I try and equate it sometimes to an annual salary. If you took home £30,000 a year, that's the equivalent of having £9 left at the end of the year.
Gosh.
Context. So
yeah, that's a good way to explain it. And now I understand how tight it was. Thank you. Okay, well let's move on then to the financial plans for 22-23. And again, we've had the submission plan from John, and do you want to just outline it as you know, people all have received it already? But
absolutely. So you'd hope that by the end of May we'd have signed off the plan for the current financial year, but we're still in the midst of a planning process, unfortunately. So the governing body's seen some previous iterations, and as commented at the start of the meeting, there was a chair's action to sign off the previous submission because that was due by the 28th of April in between board meetings. So it's what's in front of us today is the document that supported that plan submission at 28th of April. A couple of things to note. The first one, clearly, as we've mentioned in the meeting so far, the CCG ceases to exist at the end of June and the ICB takes over. This plan is for the full 12 months and kind of ignores that change of organisation, if you like. The responsibility and the money is the same and flows through. So the position we're in at the moment is a deficit, a gap of £14 million, and £10 million of that relates to excess inflation costs, particularly for us on packages of care and continuing health care, where we're seeing, for instance, increases in nationally set prices for NHS funded nursing care have gone up by about 11%, very significant market pressures within the care home market, domiciliary care market, which flow through to continuing health care. And I think it's really important to note here that excess inflation is clearly being seen as a national issue for the NHS, as it is for all sectors and for individuals, as we see every day in the news at the moment. And there's a recognition within the NHS that those conditions within which we're operating have changed significantly since the financial settlement was agreed at the end of 2021. And that's the main reason, actually, why, as a system, Norfolk and Waveney ICS has reported a planning gap of £42 million as things stand as at the end of April. That's very much in line with what we're seeing in other systems and in other parts of the country. So we're not an outlier. It's just reflecting, as I say, those significant changes in global conditions, really, since the NHS settlement was agreed. So there's been national discussion on that since, and at the end of last week we received a letter and had some communications from the national team of NHS England to say that there was a significant sum of money, further money coming out to the NHS to address some of that pressure that we're seeing from excess inflation. It's not going to cover all of the gap that we've got, but there is extra funding coming out, and there's a clear expectation from NHS England that with this extra funding and looking again at what we can do to control costs, that all systems will be able to balance their plans. So we received that on Friday afternoon. We've started working through it as a system to understand what it means for us, what extra things we think we might be able to do, if anything, to try and get back to a balanced plan as a system, and obviously for us within separate statutory organisation as well as a CCG. And so we're ongoing discussions about that over the coming weeks. We've then, all systems and organisations have got to submit a revised, hopefully final plan by the 20th of June. So then the focus is very much moving on to delivery rather than still in the planning phase of things. So we're still in limbo at the moment. Unfortunately, because of that next planning deadline, the 20th of June, we won't have another sessions governing body to be able to sign that off. So I think we'll need to work outside of this meeting to agree a process really for getting proper sign off of that submission. Obviously work with Hine as Finance Committee Chair, and Anoop, I'm sure, will be coming for Chair's approval on the back of that. And I think the final thing I would comment that hopefully comes through in the papers as well is that the plan as it stands already carries quite a significant degree of risk in there. So risk that we think is reasonable to build in, because it's right that we should be challenging of ourselves, and also it was a challenging settlement given to us. In particular, there's 3.5% of efficiency savings built into the CCG's plan. That's the best part of £19 million worth of savings that we're targeting this year. And whilst we've got plans in place for that, and none of that is unidentified, so we've got a plan for every penny of that, the difficulty is clearly in delivery of that at the time when people are flat out doing other things as well. So I'll stop there and very happy to take any questions.
Great, thank you. Thank you very much for that, John. Rob.
Yeah, thanks, Anoop, and thanks, John. You've actually answered the question I had on additional funding, John. So it's good to know that there is recognition of the pressure that we're under in terms of inflation. I thought the other good feature of the report for me is that we've identified the efficiency savings target, the 19 million that you've just mentioned. It's always good to have a plan to deliver that at the beginning of the financial year, because it maximises the opportunity for you to do that over the course of the 12 months. So again, for me, that's another good example of leaving the ICB with a good legacy to take forward through the planning work that's been done in this particular area. So again, well done, John, to you and your team. Thank you.
Thank you, Rob. Tracy.
Yeah, it might be a naive question, and I'm sure it's factored into the plan, but I think just a question for me. I mean, it's a challenging plan, but I kind of just, reading nationally that the NHS pay review body hasn't reached its kind of conclusion. It's probably going to be ongoing, but that might impact potentially, I guess. And I'm sure it's factored in, but significantly that can have that impact, I would assume. So just a bit of narrative on that, John, if you're able to give it.
It's a really good point, actually, Tracy. Yeah, I should probably have covered that before. So a really key planning assumption that we've all made, inconsistent with national direction, really, is that we plan for a 3% increase in pay costs, which includes a 2% pay award plus other bits such as the national insurance rise. There's been recognition since the outset that actually if the pay award is greater than 2%, that's a national issue. That's between the NHS and the Treasury to discuss. And you know, it's not something that we should plan for. You're right, it's a risk, but it's a risk that all organisations will be faced.
Yeah, absolutely. Thank you. Thanks for raising that and asking that question, Tracy. So any other questions or comments on that 2022-23 submission? No. Okay, and as you said, John, that there may be a requirement. Did you say that to submit, to make a further submission? And I guess within that is that between myself, Hein, and Tracy, that we may need to take chair's action on making that submission in the next few weeks. So
due by 20th of June. Sorry. So yes, we'll liaise offline on how to achieve that.
Okay, great. Thank you. So thank you very much for the hard work that's gone into this, John. I know it's taken up a lot of time, and I'm particularly been pleased about the sign up that we've got from partners within the system, which is really very different from how things have been previously. So it seems to me, to my eyes, it seems a lot more realistic and credible and joined up than it has been in previous years, and I think that's partly due to your leadership as a system finance leader. So thank you for that.
Thank you.
Okay, well, look, let's move on then to item 15, which is the CCG Green Plan, and this is for approval. Again, you'll have had a chance to read it, but I'll ask John just to kind of introduce the item and go through the salient points.
Yeah, thanks, Anoop. So complete change in tack now. I'm presenting this as I'm the SRO for the CCG in respect of the net zero agenda. So clearly a really, really important agenda, I think, that can engage pretty much all parts of the organisation and the community in which we work. And so that this is coming on the back of the NHS's net zero commitment, which is identified in the paper that was published last year, and we had a briefing to the governing body on it last September time. And part of the NHS's response to that was to say that all provider organisations and all ICSs should produce green plans by the March that's just gone. There wasn't a requirement for CCGs to do the same, but we felt at the time that it was important to do that because we've got a part to play in this as an organisation, as well as contributing to the ICS work. So that's what we've done. That's what's in front of the governing body today. I'm very grateful to the team that's pulled it together. It's been coordinated within the CCG's primary care estates team with input from colleagues across a number of disciplines, including areas such as medicines management, where there's a particular focus, communications, digital. A number of teams have been involved. And I think it makes the point in the paper that this isn't a static document. Green Plan should not be static, should there? It's a very long-term ambition that we're looking at, and we're just kind of starting on that. We're scratching the surface really in terms of what we're doing now. The more we get into the agenda over the coming months and years, I think the more and more this should grow and develop. So it's here today for comment and hopefully approval, please.
Okay, great, thank you. So any comments or questions initially? Doris.
Thanks, John. It's really good to see that we have a plan. I just have a couple of questions. One was where we're saving energy costs by flexible working, hybrid working, people working from home. You could also argue we're just basically displacing the energy consumption to people's homes. So how do we actually capture some of that? Because it's not really a saving. I'm just being devil's advocate here. And the other one is about, does the NHS actually have a policy in terms of, what is the energy efficiency rating of buildings that we use as a huge organisation? And is there any move towards setting out, a minimum standard, especially for new builds?
So both good questions, Doris. The first one, it's not taken into account. I suppose it's about the the emissions that we control as an organisation, but I think it's a valid point. Actually, where there is some degree of displacement there, isn't there? In terms of the policy for energy efficiency ratings, I'm sure it's built into building regulations within the NHS. I'm not technical from that point of view, so couldn't quote the regulations to you, but I think, for instance, some of the issues that we'll be discussing in the private part of the agenda today, with some significant developments that happen, they will always apply the latest energy efficiency requirements within them. So I'm sure those requirements are there, and perhaps we can get some detail offline to circulate.
Yeah, it was more, I was at Papworth last week and they had a sign up, and for a new build, I was really surprised how poor the SAT rating was. I did think this is a shiny new building, you know. I can't remember what it was, but I was quite appalled as I walked past and hurried to get out of the building.
Okay, thank you. Hein.
Yeah, thanks. First of all, happy to support. Good to see the plan. A bit building on Doris' points. I think it will, for the ICB, be very important to do a proper baseline. So there's not yet a lot in this green plan, but I think that would be an important action point. And also, how do we measure? And it goes a bit to the point Doris made. What measured gets done is one of the adages I work by. So that's more for future reference, but happy to support this plan. Thanks.
Okay, great, thank you. So any other questions or comments on the green plan? So taking on board those comments, can I ask you to approve the CCG green plan as it's been presented? Great, thank you very much. So item 16 again is a standing item, which is to consider the governing body assurance framework, to review the framework and which set out the current risks for the organisation. So you'll have had a chance to read through the framework. I think Karen's not here, but I think John, you're going to talk to that item, aren't you?
That's right, yeah. So as Karen's given her apologies, she just asked me to introduce it. So just a few things to pull out. I think it's the normal format we've seen recently for the governing body assurance framework. It's been subject to the usual scrutiny through the senior management team and executive leads and owners of the risks, if you like. The changes are marked clearly on the cover sheet. It's obviously links back to some of the earlier conversations, for instance, the increase in the risk around CQC special measures, which ties into the conversation earlier. Underlying deficit is reflected in there as well. Another important one, I think, to note as a new risk that's on there that's been discussed before at the governing body and the audit committee is the cyber risk, the risk of cyber attack. And obviously the risk of that has been heightened over recent months with the war in Ukraine. So that's now on the governing body assurance framework and gives a chance to see some of the measures that we've got in place, effectively to hopefully get some assurance there. The final thing to point out is the work that the team have done to identify those risks that are proposed to transfer to the ICB and those risks that should close because they're time limited. So the vast majority, as you'll see from the paper, would transfer to the ICB, and obviously then it will be for the new organisation to determine, I suppose, whether they're the right balance of risks going forwards or not. So it's here to stay for comment, please.
Okay, so any comments on the risk register as it's presented and the mitigations? Doris.
It was just a question for the team to think about. On the cancer risk, the mitigated risk is now at the acceptable risk level. So should it still be there? That's my question. It may be that actually it masks a whole load of things, that there are still fundamental issues that still needs to be addressed for the ICB.
Mark, did you want to come in on that?
Yes, thanks, Doris. I think it should stay on for the time being. I think the main reason is that we are currently sort of providing sort of cancer services at higher than pre-pandemic levels, and so, you know, for example, in terms of 2-week wait, patients being seen, we're seeing about 22% higher than pre-pandemic levels, and clearly clinicians can't sustain 22% additional work, going on, ad infinitum. So obviously need to keep an eye on that, and obviously move to a sustainable position in relation to that. So until I think we reach a steady state, I think we should probably keep it on. Thanks.
Do you want to come back on that, Doris?
No, I kind of guessed it was something like that, because sometimes the numbers just mask the underlying issues. Numbers don't tell the whole story, and I say that as an accountant. So,
okay, thank you. Any other comments or questions on the assurance framework? No. Okay. Thank you. Thank you for that. So we'll crack on and not have a break, if that's okay with everybody. So item 17, well, 17 onwards are to receive reports from the committees and clinical executives. So first, item 17 is from the Quality and Performance Committee, which Kathy chairs.
Anoop, I'm happy.
Karen, are you going to?
Yes, of course. And Mark, please join in. So I'm going to assume the paper is read. It's quite detailed. It's given more or less an exceptional report of our challenges and achievements and the impact on our services at the moment. So it looks at our three acute hospitals, community primary care and the ambulance service, and our integrated 111 and out of hours service. The report also briefly discusses an important fact that we have looked at across the system at our quality surveillance group, which is around an increase in patient falls we've observed, and it gives a detailed update regarding the quality improvement that the system has undertaken and how they take that work forward collectively as a system. So I think that's really exciting. It's seeing us working together, looking at where harms have occurred and how we take that forward as a system. So really good work. We've already had an update on the Norwich Care Hotel, and I've given a detailed report on NSFT. In terms of quality in care, we've received a really great report from the team regarding their leader annual report. And I'm pleased, I just want to draw attention, we don't always celebrate the good, but the team were awarded a gold medal in the recent deconditioning games for their discharge programme for implementation of their one-off personal health budget. And it's really important to recognise this helps our population or patients return home with care and support where they need to be, where home first is priority. Mark, I'm sure, will be very happy to take any questions on performance, if there are any. We also had a very detailed report from Mark Burgess and myself around UEC and ambulance response time and patient harms. I'm pleased to report that the tactical group that I've set up looking at system-wide harms across the system associated with either waiting for transfer or to receive an ambulance or a delay in ambulance handover. We've done some really good work there, and we're looking very much at solutions in terms of the quality improvements and using the clinical harms to drive clinical improvement. So we've seen some great work there, and I'm sure Mark will add any comments there if there are any questions. Dentistry still remains a concern for us within Norfolk and Waveney, but we had some very good updates from Tom Norfolk, one of our NHS specialised commissioners. And he gave us good information around the local clusters of dental providers that are being looked at to be aligned to our PCN areas. I know Mark and colleagues have been looking at how we can look at addressing some of that backlog as we move forward and learning from others across the system. I'm really happy to take any questions. That just gives you a flavour of an awful lot of work that's going on in the system. Thank you, Anoop, for your time.
Thank you very much, Karen, for taking us through that report. Are there any questions for Karen, or did Mark on performance that the governing body want to raise from that report? Okay, so we'll note that report and thank you again. 18 is a verbal update from Hein as chair of the Finance Committee.
Thanks, Anoop. It won't surprise you that the financial plan took center stage at the Finance Committee. John gave us the latest update, so we'll offline continue to work on that for June 20th submission. We looked at the month 12 pre-audit actuals that has been covered. We also looked at a final report out on the COVID allocations, which has been a significant amount of work for also the finance team in making sure that's all properly accounted for, and reviewed the risk register. Happy to take any questions, but that's my report out. Thanks.
Okay, great. Thank you very much. Any questions for Hein? No. Okay, well, thank you very much for your report, Hein. 19 is the report from the Primary Care Commissioning Committee, which Doris chairs, and you'll have read her report. Doris, do you want to talk through the salient points?
I think the only thing I would like to draw attention to, linking to earlier discussion on the leader report, is on the learning disability health check. Although as a system we achieved 66%, we didn't actually hit the target that was set of 75%. Whilst it is a CCG target of 75%, we are dependent on our primary care colleagues to deliver the actual health checks. And as we work towards a system, I think the CCG target is actually a system target, and we all need to work together in order to achieve that outcome for the benefit of our citizens who have learning disabilities and autism. I'm happy to take questions.
Okay, thank you. Any questions for Doris on the Primary Care Committee report? Okay, thank you. And then 20 is a report from the clinical executive of the CCG, and you have a report produced by Mark for that. Mark?
Thank you, Chair. So I think some of the items people have already seen, like the prescribing quality team in the green plan and the drug and the clinical policy recommendations. So just in terms of what's been through, the only additional thing I'd like to highlight is the priority 500 work, which is essentially work using population health to identify patients at risk of admission and take preventative actions, which is potentially very exciting. So I'd like to, apart from that, I'd like to take the paper as read, and just to say thank you to yourself, obviously, for chairing it, and Jane Bacon, who's my EA, who managed it. Thank you.
Yeah, thank you, and thank you for supporting that committee, Mark, and absolutely want to thank Jane for the support she gives in supporting that committee as well. So any questions for either Mark or myself on the clinical executive committee? Great, thank you. And then item 21 is a verbal report from the Audit Committee, which Rob chairs. Rob.
Yeah, thanks, Anoop. Very brief update for you on the Audit Committee that we had earlier this month. We received a progress report from internal audit that included a review of our risk management arrangements, and the result of that review was that we received substantial assurance from the auditors in that area, so that was a very pleasing result to see. We also received the anti-crime annual report from our specialist in that particular area, and again there's a lot of very good work that goes on throughout the year to minimise risks around fraudulent activity. Finally, just to mention, the external audit plan was received by the committee. John has already said that the external audit is in progress. At the time of our meeting, there were no matters that were being brought to our attention, but the audit committee meeting in June will consider the full results of the external auditor's work. Finally, you will receive a copy of the formal report, and if there are any questions, please do let me know by email, and I'll do my best to answer those questions. Thank you.
Great. Thank you very much, Rob, for that. Any questions for Rob on the Audit Committee? Okay, thank you very much all. So let's move then to item 22, which is questions from members of the public. And I understand that there was a question which was raised for the governing body prior to the meeting, which we should consider first. Who's going to? There we go. Georgie, you're going to. So this is the question that was raised. So I'll give you a chance to read the question, which is in front of your screens and relates to blood glucose monitoring. So I'll give you a few seconds to read, and then we'll respond to it. Okay, so who's going to give our initial response to that question that was raised? Mark.
Thank you, Chair. I think this. So thank you to the member public who's brought forth this question. It's a very important piece of guidance from NICE, which was released in the end of March 2022, so fairly recent advice. So so what we need to do internally within the CTG and obviously going forward into the ICB is to look how we can potentially implement the guidance. And I think I know that the questioner has said that it does reduce diabetes complication and is cost effective for the NHS and saving fifth time and admissions, etc. And that is correct, but what it does, but those savings don't offset the additional increased cost of actually providing the devices. And even if it did, obviously, then realizing those savings would obviously sort of mean some potential reduction in staff numbers and so forth. So just to give my give the question some reassurance that I'm very well aware of the evidence, my team are very well aware of the evidence, and we're working through the implications of this, you know, for potentially our patients. And obviously we also need to take account what the potential cost is, given John's previous presentation as well, and we'll come to a balanced view as to how we implement this policy. Thank you. Okay, thank you for that. And as we said earlier, we'll publish the full response to that on the website to that question. Are there any other questions that have been received during the meeting?
There aren't, Chair. There's none that have come in, and there's none on social media.
Okay, thank you. And are there any members of the public who are in this meeting who'd like to raise a question at this point, if they could raise their hands? No. Okay. So
Anoop, there's somebody on the screen, I think Mark Langland.
Yes, I've just seen Mark Langland's. I couldn't see a hand up, but I can see Mark Langland's. Are you wanting to raise a question, Mark? If you could just briefly, if you don't mind, just say what who you are and what your question is, please. If you wish to. You'll need to unmute because we can't hear you. I think you might be muted on your microphone. You may be trying to talk, Mark, but my screen is showing that your microphone is switched off. Are others in the same position that they can't hear what Mark is saying? Unfortunately,
I can't hear either, Noob, sorry.
I think there might be a technical problem, unfortunately, Mark. I can't see that we're going to, unless something improves with the technology in the next few seconds, it's going to be difficult to get you to kind of raise your question at this meeting. But as I said earlier, if you're not able to ask now, you can ask questions after the meeting, and we'll cover that through our website. So apologies if the technology isn't allowing you to ask a question, but I think it's your microphone that isn't working, unfortunately. Okay, thank you. Is there anybody else that wants to raise a question or any comments from governing body members in terms of how we manage that? Mark?
Anoop, I've just changed Mark's setting to make an attendee, so I don't know if that makes any difference to him being able to unmute.
First of all, Mark, can you just give me a thumbs up if you can hear me? Yeah, we're trying our best to be able to hear you, and we're trying to set permissions if that's the issue. But I've got your microphone having a cross through it, which suggests that it's either muted or not working, which will make it very difficult for me to know what your question is if you're trying to raise a question, unfortunately. So I think we're going to have to, unfortunately, give up on that, which is unfortunate. If Mark was has sort of patiently sat through the meeting. Jossie, are you going to help me?
Only could he put his question in the chat, Chair?
If you can, that'd be great. I'm not sure if that facility is there, because I think previously at meetings we've not had that facility to chat on the governing body meetings, but I mean, I'd be happy to take that as an exception if we're able to do that, because I think it's actually really important that that Mark, if he sat through the meeting, is able to ask the question. I think it's really unfortunate that the communication, the technology at this last point is failing us.
The chat function has just been enabled.
Okay. Do you want to have a go, Mark?
You need to type the question into the chat box.
Are you typing the question in? Just give me a thumbs up if you are, and we'll wait patiently. I mean, I can see the abilities there to type questions. So I assume that you're typing your question now. I shall wait. Right, so thank you. And is this in relation to, do we know what this Mark's question is? How long do we have to wait before we're in a position to make a decision? Do we know what that's in relation to?
If I'm thinking rightly, Chair, I think this is in relation to Freestyle Libre. Nice guidance.
Okay, thank you. Thank you, Mark, for asking the question. So, Mark Lim, are we able to answer the question as to how long we'll have to wait before we're in a position to make a decision on implementing the NICE guidance?
Thank you, Anoop. So I'm not aware of the precise committee dates of the incoming ICB, but I think in terms of us from a mentors management team perspective and doing the work up, we should have that done in a couple of months, and then obviously whatever it will go to the next available committee meetings in the new ICB.
Okay. Well, look, thank you, Mark, for raising the question, and can I ask Tracy perhaps to make sure that is addressed within the ICB in terms of being able to answer the question on implementation of the NICE guidance on that. So with Tracy continuing in her role, she'll be able to answer the question as Chief Executive and Accountable Officer for the ICB. So thank you for your patience, Mark, and I'm sorry that that it took some while for you to get your question out, but thank you for that. Are there, if there are not any other further questions, then we've reached the end of the agenda item. So is there any other? Thank you. Is there any other business from governing body members? Okay, so it falls on me to close the meeting, but I just wanted to say a few words and recognizing really what I said at the beginning, that this will or is the last meeting of the Norfolk and Waveney Clinical Commissioning Group in public before it ends on the 30th of June. As I mentioned earlier, the Integrated Care Board will take over responsibility when it's established on the 1st of July. And I just wanted to, on behalf of myself and the CCG, really wish the ICS and Patricia great success for the future. The ICB board will build really on what I feel has been a great success from Norfolk and Waveney CCG, but also CCGs before the single CCG was created in Norfolk and Waveney, and as governing body members know, I was personally involved in North Norfolk from CCG when it was established in 2013, and there are governing body members here who were chairs of the other CCGs, so Tracy and Hilary from Norwich and South. So I wanted to thank them and all the people that worked within all the CCGs in Norfolk and Waveney previously. I think CCGs have done an immense amount of work, particularly in terms of clinical engagement and involving primary care, which has been hugely successful in Norfolk and Waveney. The last 2 years that I've chaired Norfolk and Waveney CCG, they haven't at all been how I thought they would be when it started in 2020, because the CCG was formed really exactly at the point when the pandemic struck. So the challenges that we faced have been huge, and it's been the biggest global challenge that the NHS has ever had to deal with, and it's very much dominated. The pandemic has very much dominated the work of the CCG and the system, and I think we've made enormous progress actually in the last 2 years, and I just want to thank really all the staff for the efforts that they put in. Particularly, I think at the outset, from the outset, we really geared up with the vaccination programme, with maintaining services, and particularly I wanted to thank colleagues within the CCG who worked outside of their comfort zones at a very stressful time when they were having stresses with their own families and friends. They actually went out into the community delivering PPE in primary care, which wasn't in their job description. They took personal risk in doing that, and I just wanted to thank them for their bravery and really hard efforts that I saw at first hand, and I was really humbled by seeing that. I'd like to just take the opportunity to wish members of the CCG who are continuing, and I know the majority have got roles within the ICB, which gives me great comfort really to know that there'll be continuity of the experience and expertise that's there within the ICB, because I know it's going to continue to be challenging, particularly post-pandemic, getting back to the new business as normal. It's going to be a huge challenge, and I'm pleased that there are senior members, clinical members, but also executive members that will be working within the ICB. I wanted to personally thank the governing body of the CCG for their efforts over the last 2 years. It's been enormously supportive for me to do my job, knowing that I've had governing members who've worked with me and supported me and the work of the CCG. So I wanted to thank both the lay members, the senior executive members, and the governing body clinicians for their support for me in supporting me in chairing the CCG. And finally, I just wanted to look forward to seeing the increased work of the ICB, the strengthening partnership that's going to be the ICB as it moves forward. And I wish everybody success in whether they're involved in the ICB going forward or the ICS, or if they find new roles. I just wanted to wish everybody success in the future. And once again, thank you very much for your support for the CCG. There isn't a further meeting in public, so thank you, everybody. I'll finish there. Just a reminder for the governing body that we have got a second part to follow, which I think we will continue at 3:30. So it just gives us a little bit of a break before the next part of the meeting. Mark.
I know those words were all very helpful, and thank you very much for those. I think it'd be remiss if we didn't, on behalf of the governing body, also thank you for all you've done over the last 2 years. It certainly hasn't proved to be the format we envisaged, and I think the style you've adopted as chair of the CCG has been really helpful. And I think if we'd been told 2 years ago that we wouldn't actually have been able to meet face to face at all, we would have had real reservations about whether we could have operated effectively, but we've done so, and I think that's in large part down to the way you've chaired the CCG. So thank you on behalf of us all for that.
Thank you for those words, Mark. Okay, well, look, we'll close the meeting there, and thank you all, and see you in 20 minutes or so. Thank you.